Today we'd like to welcome Dr. Assanasen, right? Well, it's pronounced Abrahamian enough times. Dr. Assanasen is the Chach. That's what he's known by. He's the medical director of the Children's Health at University Health System, the South Texas Pediatric Blood and Cancer Center here in San Antonio and Health Science Center, and distinguished chair in pediatric oncology at the Children's Cancer Research Institute. He has expertise in the area of complement inhibitor use, specifically Eculizumab, in complement-related diseases such as atypical HUS. Recent publication out of this institution by our pediatric group on the use of Eculizumab for prophylaxis in kidney transplantation in a child with atypical HUS was published this year. And he's going to talk to us about the use of Eculizumab in atypical HUS. We've got several patients on the pediatric side and I think on the adult side as well, maybe. Controversial. So without further ado, Dr. Assanasen. Yeah, let me put it on. The closer to your throat, the better.
All right.
And then you can shove that somewhere.
Sounds good. All right. Well, as you heard, my name's Chach. It's long. Believe it or not, my brother's name is Ben on his birth certificate. So I'm going to, as Dr. Abrahamian mentioned, I have a little interest in the role of complement-related disorders, and I came about this kind of the back end where I had some patients that really required intervention with a complement-related disorder called paroxysmal nocturnal hemoglobinuria, and really saw the effects and the benefits of complement-related inhibition and its role in many different diseases, atypical hemolytic uremic syndrome being just one. So I have a few disclosures. I am on the Speakers Bureau for Alexion Pharmaceuticals as well as Jazz Pharmaceuticals. However, during this talk, I will be discussing many things that the pharmaceuticals do not permit people to discuss because it is off-label use, specifically with a lot of the data regarding other uses for Eculizumab. Objectives, I will, in this setting, have an overview of the complement system, the regulators of complement activity, the role of complement in atypical HUS, which actually really helps us define and understand how we need to intervene in this disease process, and the directed therapy for atypical HUS, specifically with the terminal complement-related inhibitor Eculizumab, although I will discuss some other molecules coming down the pipe. Eculizumab's use in the setting of renal transplantation, because this is a transplantation conference, and specifically looking at some of its use in antibody-mediated rejection as well. So the early history of complement. Oh, and by the way, I tried to focus this talk a little bit, but feel free to ask any questions because we do have our little atypical HUS working group here in the room with me to provide some support in case I get a question I can't answer. So the early history of complement, and it really began with studies regarding the Pfeiffer phenomenon of bacterial cell killing. At that time, which was back in the 1800s, there was identification of a thermolabile factor in normal serum that really enhanced immune activity. Ehrlich actually coined the term, and this optimal reaction of this immune destruction depended on two principles. And that was the presence of the immune serum, fresh or heated, which they later called amboceptor, or now we know as antibody, and the presence of a fresh, unheated component in the non-immune part of the system called alexin, where alexion actually comes from, or complement. And complement's actually designed to help us fight off natural invaders. It was originally thought to be just one protein, but now we know that it is at least 27 proteins. And the localization is primarily on the membrane surfaces. So the way we can kind of understand this is as a very primitive form of a part of the immune system that actually identifies a foreign invader, say a foreign little bacterium, and will actually drill holes, and we'll have some pictures here for everybody, into these foreign bacteria. It again is a vital component still of our natural protective immune system, and its function is primarily to disrupt cellular membranes. It has an activation pathway and an amplification pathway. And from inactive to active, there are actually three pathways that I'll actually describe and illustrate, and then we won't show you any more pathways. Because of these pathways, they are very highly regulated to return to their inactive state. And this is the complement pathway. As you can see, it is comprised of three main pathways: the classical, the lectin, and the alternative pathway. The lectin pathway is actually that primitive pathway that we can think about, where it's activated by a membrane-bound ligand to activate and cleave C3, later on activating C5 convertase to cleave C5 and build that MAC complex, or that pore in the cell membrane. The classical pathway is actually termed classical because it interacts classically via an antibody-antigen interaction. And there's a C1QRS and ultimately goes down the same pathway. The C3 is, however, a molecule that can also be very water labile. It has a tick over so that it can actually be in its active and inactive state within the same area. So what happens in this alternative pathway is that it can actually continue to feed itself or activate itself within an aqueous solution, ongoing and basically driving this pathway down to that C5 cleavage. So as you can imagine, you need a lot of inhibitors to try to hold back this pathway. And the goals of this pathway are primarily a very fast pathway to really start and really just kind of overwhelm a quote-unquote invader once it's identified. Now, some other unique aspects of this pathway are that the other components actually have activity as well. So the C5a, in and of itself, is very prothrombotic. It can actually act as an aflatoxin as well, encourage chemotaxis and cell activation, and is very pro-inflammatory. Likewise, as you can imagine, that membrane attack complex is as well. Now, when I think about the complement system, I think about what I usually do on a regular basis is think about the coagulation cascade. And it really kind of allows me to really kind of understand how this system really works. You have in our coagulation cascade that we all have learned and are very familiar with, the same pathway from tissue factor triggers to amplification. And we use heparin right here at the terminal component, antithrombin, to be able to kind of control and inhibit some of its more destructive procoagulant activities. So similarly, with the coagulation pathway, we have a same driving force, an amplification, and now we have a tool that actually can inhibit that C5 terminal complex from eliciting more procoagulant and other cellular destructive clinical activity. And these are some EM pictures of that. As you can see here, these are little holes that the MAC complex has developed, as well as subsequent endothelial damage and inflammation. Now, some points that I need to make here, that this pathway, just like your coagulation pathway, is always on, and that's to allow the rapid immune response. Complement activation, it really has the potential to just really kind of overwhelm and cause really severe damage. And that's what it's supposed to do. However, without that very strict regulation by the inhibitory proteins, it can go on to damage not only its targets, but also surrounding tissue vis-a-vis the endothelium and surrounding cellular structures. We do know that complement's involved in many disease states, including PNH, as I mentioned earlier, atypical HUS, things that you may also be excuse me, familiar with in the room. That's like antibody immune complex disease, MPGN, recurrent fetal loss infections, lupus, HELP syndrome, eclampsia as well. We are going to talk a little bit more in depth about atypical hemolytic uremic syndrome. It's a very, very rare disease. As a matter of fact, it's classified as an ultra-rare disease. It's an incidence of 1 to 3 per million people per year in the United States. Comparing that to some of the children that I deal with more often, acute lymphoblastic leukemia, we generally expect to see about 30 per million. Its presentation can be varied. More commonly, it's seen with renal dysfunction and other complement-mediated evidence of thrombotic microangiopathy, or TMA. However, any organ system can actually be affected. When affected, 30 to 40% of patients actually die or progress to end-stage renal disease within the first clinical manifestation. And it is a very chronic progressive course with very premature mortality. You have this pathway that's just kind of overactive, and it is, there's nothing holding it back. The 1-year mortality / dialysis / permanent renal damage statistic is about greater than 50%, despite a more classical intervention of plasma exchange or plasma infusion. It is a genetic disease, as it is understood, but it can manifest at all ages. And we are in the process of investigating some of the possible cofactors that may be involved with some of that, which I'll mention a little bit later when we talk about some of our genetics. So back to this pathway, as it is genic loss of inhibitors. So we do know a number of these inhibitors, but we don't know all of them. Some of these inhibitors that you can see here act directly between C3 and C5 convertase and go on to elicit further damage as consequences. From a more macroscopic viewpoint, we see activation of this pathway by some trigger of sorts, going on to cause a cascade of destruction downstream, which will cause further endothelial damage, subsequent platelet consumption, anemia, development of schistocytes, which is actually the hallmark of when we look at thrombotic microangiopathy or MAHA. Ultimately, blood clots, inflammation, further occlusion, ischemia, and hypoxia. As a hematologist, I also kind of think of this in terms of the way we think about sickle cell disease as well. So as with sickle cell disease, there are a number of organ systems that can be affected, kidneys being one of them, but also there are many reports of cardiovascular complications, including myoinfarction, cardiomyopathy, pulmonary diseases such as dyspnea, and pulmonary hemorrhage is actually a fairly distinct finding in a lot of patients. CNS is also involved, and this becomes an issue with regard to sometimes diagnosis, because a lot of the hallmarks of atypical HUS are very similar to other thrombotic microangiopathy diseases, such as thrombotic thrombocytopenic purpura, or TTP. Gastrointestinal complications, including diarrhea, which if you have a patient that presents as such, one of the differentials would be, is this just a quote-unquote typical HUS, or what we would term as a STEC HUS? And diarrhea seems to be present in both atypical and typical forms. And as far as very, very minimal complications, you may just have fatigue or reduced mobility. But you should see specific hallmarks. So there are diagnostic testing criteria. This was published by Kavanaugh in our American Society of Hematology education program book at our society meetings. However, it's not really very practical. Serum levels, because as I mentioned earlier, this is a membrane activity for the most part. So serum levels of C3, C4, factor H, and factor I don't really correlate with a true diagnosis of atypical HUS. You can measure MCP expression. This would help you with respect to one specific form. Mutational screening for genetic mutations is often done. As we'll mention in a later slide, this is only positive in 30 to 50% of the time maximum. It takes about 3 months or so to get back. Screening for factor H autoantibodies is useful in the event that it is an autoantibody, but not a true mutation of one of the inhibitory proteins. And the measurement of Adams TS13 allows you to help you with the differential. Nowadays, that has become much easier. In the past, it usually took 2 weeks or so to get an Adams 13 activity back, but now we are able to do that within 24 hours. By definition, atypical HUS will have the criteria of a decreased platelet count, evidence of microangiopathic hemolysis, schistocytes, helmet cells, whatever you'd like to call them, little frisbees. Evidence of organ impairment. And again, it doesn't necessarily have to be the kidney, but the kidney is usually the most sensitive organ, and more commonly seen is a rise in serum creatinine. We do have to differentiate it from other forms of TMA, such as TTP, and Adams TS13 activity greater than 5% will generally exclude TTP. And then it's easy to get a sugar test to exclude sugar toxin. There really is no requirement for genetic mutation, again, but it does help you if it is positive. One of the reasons we have some difficulty with the genetic mutations, it's only been identified over the last 20 years. This is a little timeline which I was able to kind of move over, and you can see it's really this last decade that we've been able to actually identify a lot of these mutations. A patient that we are currently working on the family cohort on actually has this C3 mutation, and I have a sneaky suspicion that he was part of that initial identification. These are the known genetic abnormalities, or the commonly known ones that have been published. This was from 2009. As you can see, the more common is congenital factor H abnormalities with a frequency of 20 to 30%. Our patient who has a C3 mutation has a much rarer frequency. However, the outcomes following kidney transplantation are also listed in that column, along with long-term outcomes. You can see that the rate of death is fairly high, except for one, which is right here, which is that membrane cofactor protein. So this protein is actually membrane bound. So theoretically, once you transplant the kidney, it's already coming with that membrane bound protein, which can explain some of the significant improvement and low rate of recurrence in that disease process, or that mutation. However, again, this is a systemic disease, so once you transplant a kidney, you're allowing that kidney to be a target for the ongoing disease process throughout the body. So this is our patient, or one of our patients. We follow a few patients with atypical HUS. And this patient it came to us actually from Dr. Alakash in Corpus. He is this little black box all the way at the bottom here. He had significant renal disease that it required 2 kidney transplants, and we met him on his 3rd kidney transplant. He was characterized with a C3 mutation, and we have been working with the family as far as identifying who also in the family may have this C3 mutation and who actually has clinical manifestations and does not. So the black filled in circles or squares demonstrate somebody with clinical disease. And the pluses and minuses actually identify patients who have positive genetic testing and negative genetic testing. As you can see, there's a number of patients that have not manifested. Whether or not there are other factors involved which allow them to either compensate to some degree, or whether or not there are cogenetic factors that inhibit the expression. It's unknown, really, at this point, but we do know that adults have presented with atypical HUS without previous symptoms before. So the way I tend to think of it is kind of like the way we think of patients who are hypercoagulable. The risk factors are all there, and as they stack upon each other, say, for example, a young lady with factor V Leiden who's also pregnant or on OCPs, she may have a clot later in life and not necessarily have it prior to that. But we are in the process of working out this pedigree, as well as trying to identify a golden test to be able to kind of clinically identify patients who actually need intervention and not, which is the name of the game these days because of the cost of this drug. And because of the cost of the drugs, people are looking at alternative therapeutic options. Plasma exchange and plasma infusions have been the classical therapy modality for this, possibly because of its similarity to TTP and its use. But plasma exchange and infusion, you're basically taking out bad humors and putting in new, although the half-lives of these factors are fairly short, and you cannot expect that the factors will remain within the system for probably much longer than a week or so. Although there are complications with plasma exchange, plasma infusions in and of themselves, because we know that 65% of patients die or continue with dialysis or further renal damage after the first year after diagnosis, even on plasma exchange or infusion. And as I mentioned, and I will continue to mention, it really doesn't target the actual pathway of uncontrolled complement activation. We do know that there are other biomarkers that we can look at, such as platelet activation and complement activation, that show that even with plasma exchange and infusion, complement activity continues to go on robustly.
Todd, can you go back to the pedigree slide?
Yes.
Can you explain to the group the inheritance pattern? Meaning, does one parent have to have any mutation? Both? How is that?
It is autosomal dominant. So, yes, C3 is. Others are a little different, but this patient, C3 is. So, having a mutation, you will have the clinical risk of the disease. It can be female, male. It does not have to be co-inherited with any other process. Lindsay, our genetic counselor, may have further details with regard. I think it's 1 in 500 is and then there's a presence, and then whether or not there's any kind of expression, but it's fairly highly variable.
53% penetrance with the C3 mutation. So even when they test positive or in a tell your chance of having it is higher than average, but it's not a guarantee. But the predisposition still.
Mhm.
But yeah, it's a 50-50 to unheard of.
So when you're early on, you said 1 in a million
Mhm.
have atypical HUS,
Mhm.
meaning the chances that that 1 in a million got together with that other 1 in a million is that?
So they don't both have to have it.
They-
That would be
yeah.
recessive. And
That would be
all
recessive, so-
inheritance happens for AHUS, but with C3 it's not.
Oh, I'm sorry.
Yeah. It's dominant, and that number 1 in a million need to be altered because of this question of the penetrance and how much is actually really out there as far as mutations and what could be triggering the actual disease process to become active. So,
In this particular family, and I happen to be familiar with this
Mm.
family, all the family members have the disease as adults, except our patient. I think I did 3 months of them.
right.
So generation 2, number 1, that's the boy who was 7. They just found that out very recently.
Which board?
In generation 2 or the
Okay, so
first
this is a new,
that's new
found
information.
patient. Okay, so what's the total number of patients here?
How many do you have so far, Lindsay?
Well, in these 2 generations, we've tested about 13 or 14. No, positive is 200. 9 positives.
Sorry.
Oh, no, by all means. So other therapeutic options that people have used and are continuing to use are the combination of plasma exchange with immunosuppressive agents such as corticosteroids, chemotherapy agents, or rituximab. Now, rituximab, I can understand its success rate in the setting of auto-H antibodies, but not in the complement-mediated pathways. I find it kind of amusing, actually, because rituximab was initially designed or developed for non-Hodgkin's lymphomas, and now it's enjoying widespread use because of the understanding of how CD20 cells interact with autoimmune-related diseases or lead to autoimmune-related diseases, which is, I'm hoping, how Eculizumab and these complement-related inhibitors will move forward, and hopefully the cost will come down and be less prohibitive. People have continued to transplant patients with varying or minimal degrees of success because of the disease reemerging in that new kidney. And then there are direct complement inhibitors, which Eculizumab is one. There are, however, many that are currently being evaluated in phase trials and preclinical trials. As you can see, they're all targeting different aspects of the complement pathways, some of which are a little higher, some trying to access the lower complement at C5 or C3 level. However, Soliris is actually the only one we have available to us now. It is an anti-C5 antibody that blocks the complement-mediated thrombotic microangiopathy. It binds with high affinity to C5, that terminal complement molecule, prevents it from forming the MAC complex and cleaving into C5a. The proximal functions of complement, anything above that, will still be intact. So you still have some activity of complement with a weak aflatoxin, some immune complex clearance, and some opsonization properties, but you will not get that cellular membrane destruction with this blockade. This is the dosing schedule for adults, and the dosing schedule is primarily an induction period with about weekly doses, followed by, excuse me, every 2 weeks dosing, and that's based primarily on the half-life of this medication. It is an inhibitor by definition of part of the immune system, so that these patients are immunosuppressed. And in early studies, the most significant complication was meningococcemia in patients exposed to meningococcus. So there's a black box warning. You need to have your vaccine prior to administration, or get the vaccine and continue prophylaxis with antibiotics to be able to start this medication. And patients need to be aware that they are immunosuppressed. It is actually unique that it's one of the only approved medications in pediatrics for an indication of atypical HUS. And as many of the people in this room know, this is a rarity in pediatrics, where you actually have a drug that we use that's actually approved for an indication. We're going to mention a little bit about the data that kind of went behind this, but we are very happy that this is the case, because our patients who do have this disease are able to get this medication because of this approval. So now let's talk about atypical hemolytic uremic syndrome in renal transplantation. So anywhere between 50 to 80% of transplanted patients experience some type of recurrent thrombotic microangiopathy in a transplanted organ. And those with recurrent thrombotic microangiopathy, up to 80% of those patients will experience graft failure. There's a statistic of less than 38% 5-year survival. This is primarily renal transplant patients who have recurrence, lose their graft, and then go on to chronic dialysis. There has been discussion in Caprioli's proposals and discussions that eculizumab may actually increase graft survival post-renal transplant by preventing systemic thrombotic microangiopathy. And it makes sense. You're preventing further damage from that fresh kidney. So this is the New England Journal of Medicine article that was published last spring, I believe, by Legendre et al., titled Terminal Complement Inhibitor Eculizumab in Atypical Hemolytic Uremic Syndrome. And it's comprised of actually 3 studies that went on to be evaluated by the FDA to really obtain this indication. And there are small differences within this study. So they're termed 3, 2, and 1. It's really kind of weird that they just used numbers. So 003 was comprised of adolescents and adults. And as you can see, the numbers here are very small. This is an ultra-rare disease. But the primary difference was the range between the duration of diagnosis of atypical HUS to intervention. And that was a longer duration with a median of about 48 months in this group. The second prospective study cohort, 002, utilized or grouped patients together that actually were identified and intervened much earlier at 10 months of median duration. There was also a retrospective pediatric study that kind of went further down into the age groups as well. So what they were able to identify was that uncontrolled complement activation was inhibited. Complement-mediated thrombotic microangia was inhibited as designed by this molecule, and that the burden of interventions was reduced. Some of these patients were already on dialysis. Some of these patients were receiving other interventions such as plasma exchange as well. Now, what was interesting is that when they looked at the renal function of these patients, those that were identified early in this 002 group actually had improvement in their renal function, so suggesting a reversal of some of the prior damage. Those that were identified later weren't able to get that improvement, but they were able to be maintained on the current renal function that they had. So suggesting again that the damage that can happen if it persists can lead to permanent damage which cannot be reversed. Now the cohort, the pediatric retrospective cohort, 19 months, kind of somewhere in the between these two, was somewhat as expected in the middle as well. There was some improvement, and when we looked specifically at dialysis, half of them were able to come off dialysis, and all of them did not go on to any new dialysis if they were not already on it. Similarly, for the other cohorts, same findings. Those that were identified and intervened late, no new dialysis. If you intervene early enough, you can actually eliminate dialysis or interventions in a significant percentage of these patients. And overall, like any other biologic agent, there are some complications. Those that have been identified include kind of myalgias, some fevers, aches. We've been using it in a number of our patients and really haven't had any significant complications. It's a very easy drug to infuse. It infuses over 35 minutes in adults. In pediatrics, it was 35 minutes. All of a sudden now they're saying, oh, infuse it over an hour. But I don't know where they came up with 35 minutes to begin with. It's a very small volume. But it's very, very well tolerated. So Legendre presented at the American Transplant Congress in 2013 some sub-analysis within these cohorts. And this is a table from that poster. This was a sub-analysis of 003. Again, these are patients that had been diagnosed with atypical HUS, but were delayed in that intervention. So what is interesting here is that you can see that within that, you see that the platelet counts were maintained. The EGFR were fairly similar as well. The mean time to clinical manifestations were about the same. And there was no real dramatic significant change. This is a little weird because the platelet count actually was reversed, but there's a little asterisk there that the platelet count was at 150 and was maintained. And in the renal transplant population, I can imagine that they may be due to some other medications that they may be on as well. Now, she also presented another poster doing that sub-analysis of data on renal transplant patients in those populations, on those that were intervened earlier, again, the median time of 10 months. As you see, there's a significant improvement of mean EGFR here, as well as the mean time to clinical manifestation obviously was a little improved, and that mean change of platelet count from 72 to 131, as well as the mean change in EGFR. So again, demonstrating that if you can intervene earlier in these patients, you can expect or hope for a better improvement in the clinical symptoms that you're dealing with. So what about the use of Eculizumab for atypical hemolytic uremic even in recurrence, and using that to either prophylax or treat the recurrence of atypical hemolytic uremic syndrome? So Zuber did a retrospective multi-center analysis looking at patients who have been treated with Eculizumab as a prevention or in treatment for post-transplant manifestations. He was able to find 22 patients and divided them basically into two groups. Those patients that received Eculizumab prophylactically to prevent manifestations, numbers are really low here, N of 9, and as well as patients who received Eculizumab to treat post-transplant manifestations, N of 13. So with the prophylactic use of Eculizumab, he had a strategy consisted of one of three methods he found in his retrospective view. One, sequential prophylaxis, where the plasma exchange was given just before transplantation, then it was switched to eculizumab right after transplantation, or a strategy of giving eculizumab prophylactically with the initiation of eculizumab at least 1 week prior to transplantation, so you're in that weekly induction phase at the very least, and continuing on, possibly getting a steady state, so to speak, or eculizumab therapy alone, where eculizumab was actually initiated the day before, or less, the transplantation, and then another dose immediately given before or within 24 hours after transplant. So basically a double dose just right around the transplant. So what are some of the data? So 8 of 9 treated with eculizumab maintained the allograft function with no additional atypical HUS manifestations, with a mean follow-up of about 14 and a half months. Optimal C5 blockade, as measured in their case by C5-dependent functional activity, was achieved in about half of the patients. Now, with this data, they went on to provide recommendations. So his recommendations are primarily divided into risk levels: low, moderate, and high. So the low-risk patients, going from the bottom up, are patients who have an isolated mutation of MCP. Again, that very rare mutation that really is that membrane-bound protein that will actually be quote-unquote transplanted with the kidney, and does not have any evidence of any antibodies as well. And those patients can actually be monitored without any intervention. The moderate risk are the more commonly what we'll be dealing with, where the mutation is unknown, or the functional significance of the mutation is unknown, or you may have a patient with CHF antibodies. And his recommendation for that patient population is a prophylactic therapy with eculizumab using eculizumab alone instead of plasma exchange to prevent post-transplant atypical HUS manifestations. The first dose should be given on day 0 prior to surgery, and an additional dose given within the first 24. So he's actually advocating that big bolus dose right around the transplant. He does comment on when you would consider discontinuation, and he comments that discontinuation may be attempted after a 12-month period of atypical HUS manifestation-free period of complement blockade. So it sounds like you would continue it and then maybe stop for a year and then watch and see what happens in that year, and maybe say, okay, maybe I don't have to continue it after that year. Again, as a hematologist, I can, the analogies to hemophilia and other coagulopathies is right there. These are the same debates that we have with a lot of our coagulopathies. High-risk patients are patients who have experienced significant manifestations in a previous graft, those with mutations associated with a high risk of manifestations, congenital factor H mutations, etc. What he doesn't really comment on, these are patients that have already lost their kidney to atypical HUS. So his definition of high risk is somebody who's already had manifestations in a graft that is already in the body, where the patient's already lost their 2 other kidneys to the disease process. So he's advocating, in this case, prophylactic therapy with eculizumab, and it should be used instead of plasma exchange, plasma infusion, to prevent post-transplant manifestations. And in this case, the first eculizumab dose should be given on day 0, again, that big bolus dose, which when we talk a little bit about some of the data that we have here on our pediatric patient, it would suggest a similar recommendation. So the group that he evaluated that used post-transplant eculizumab just for clinical manifestations, 13 of those 10 of those 13 had post-transplant biopsy evidence of TMA. So this was true reemergence of their atypical HUS, not another disease process. So while receiving eculizumab, hematologic features returned or remained normal with significant improvement of the renal function and creatinine in these patients. So once you gave the dose, the response is very dramatic and immediate. 2 of the patients received single dose of eculizumab, but later had further manifestations 21 and 11 months down the road afterwards. Okay, so you give 1 dose and later down the road, you really don't have anything helping you blockade that damage, and you can't expect to have further complications. Delays in eculizumab administration occurred in 3 patients for various reasons. None were associated with any severe illness or from the immunosuppression, but longer delays between the onset of atypical HUS and the initiation of eculizumab were associated with lower renal recovery. Again, the analogy of that prior C003 versus C002, the longer it's in that environment and being damaged by the the complement system, the more likelihood that you're having more permanent damage and cannot recover. Post-transplant use of eculizumab recommendations or results. Eculizumab should be initiated immediately for the treatment of post-transplant atypical HUS. Treatment of complete and incomplete presentation should be treated the same. Evidence does show earlier initiation led to greater recovery. And plasma exchange and plasma infusion, again, has not been shown to improve graft survival. Switching to eculizumab may result in additional improvement in renal function or hemoglobin levels. With liberal renal biopsy policy is recommended because there are other disease processes that can present similarly, especially in the post-transplant environment. Single dose regimen should not be used because these were consistently associated with further damage down the road after the eculizumab half-life ran out and you didn't have any further complement inhibition. In moderate risk patients, again, going back to his risk stratification, in the current or previous graft, discontinuation may be eliminated, again, after this quasi 12-month manifestation-free period. So kind of riding the fence there, which is similar to what we do with a lot of our hemophilia patients. So this is actually our patient that we, I guess, piloted. Barrett, was this the first patient in this university? So this was our patient who had a C congenital factor H mutation, and the recommendations by Zuber were not currently available at the time. We, however, did feel that providing as much inhibition as possible was best, and I'm not sure if you can see the bottom arrows here, but this patient was on maintenance or every other week dosing, and we made sure that we provided a dose right before the transplant. However, shortly after transplant, we started seeing signs of thrombotic microangiopathy, microangiopathic hemolytic anemia. Danny called me and said, "Chach, I think I see schistocytes." And yeah, there were a schistocyte or 2, and then the LDH started rising. So we got on the phone and spoke to a number of colleagues, and they agreed with our recommendation to provide another dose. And this is a medication that is not reimbursed as an inpatient. So this was not to be taken lightly. As this drug is, I think it's still the most expensive drug in the world. So we did give another dose, and we're able to see that these biomarkers were actually improved. However, in hindsight, we also were able to do testing on C5 activity and eculizumab, quote-unquote, levels. And we identified that we were actually at super recommended levels. suggesting that the recommended levels in the setting of severe stressors, and Zuber kind of alludes to this where he recommends a big whopping double dose right around the transplant, may help prevent breakthrough of the complement cascade in initiating damage further down the road. In our report, we actually were able to talk to Dr. Bedrosian, who's the chief medical officer of Alexion, and she was able to tell us that there are actually some other markers down the pike that may be more sensitive as far as providing appropriate inhibition of C5, and she called it a free C5, which, to my knowledge, they're the only ones that do that right now. I don't know of any lab that, or research or otherwise, that is doing a free C5 level. So finish up a little bit here with antibody-mediated rejection, because I think this is something that is discussed in this setting often, and I believe I had heard that somebody was treated with Eculizumab for AMR here. No? It was a lung? Okay. All right. So by review, AMR, you probably know this, all it's just tissue injury related to alloimmune responses. There's two types of tissue injury, AMR, which is a humoral or antibody-mediated rejection, versus a T-cell mediated, which is termed ACR. AMR represents about 1/3 of acute rejections following kidney transplant. And it's the complement activation in response to donor-specific antibodies binding to donor endothelium that play an essential role in acute AMR. So the thought is that the formation of the MAC complex and C5 as an aflatoxin promote local inflammation and further tissue damage, resulting in allograft dysfunction. And here's that EM picture again of what the complement's doing to these cell walls in the endothelium and graft and with other tissue structures, just all these little holes that can go on to develop further inflammatory processes. So Stegall, I guess, Stegall, thank you, in 2011 published this paper on terminal complement inhibition, that decreasing antibody-mediated rejection in sensitized transplant patients. And the goal was to evaluate the efficacy of terminal complement blockade, Eculizumab, and for reducing the incidence of AMR during the first 3 months of kidney transplantation. It was a single-arm, open-label study comparing transplant to historical controls, but received either Eculizumab or standard of care plasmapheresis and IVIG. So the study design was they diagnosed the AMR using BAMF criteria with graft dysfunction or creatinine renal dysfunction or renal criteria. They obtained baseline donor-specific antibodies and compared those with periodic measures throughout the study period, as well as within the Eculizumab treated patients, they underwent specific periodic biopsies during that study period post-transplant as well. And the way that they administered Eculizumab is a little convoluted, but I wrote it all down here. It was administered at a whopping 1,200 milligrams immediately prior to transplantation, and 600 milligrams, again, an extra dose post-operative day 1, and then weekly, which we would expect as a regular induction regimen thereafter for 4 weeks. At week 4, it was discontinued in patients whose DSA has significantly decreased, and week 4, it was continued at 1,200 milligrams week 5, and then every 2 weeks for patients who had persistently high levels of DSA. And at week 9, it was discontinued if there was a significant shift in that BFXM channel. Additional doses were administered in 3 patients who received plasma exchange post-transplant. The dose was administered within an hour of completing the plasma exchange to ensure levels were sufficient and completely block complement activity. And what are the outcomes? So the outcomes show that At 3 months, the incidence of AMR was low at 7.7%. Eculizumab group versus 41% in the historical controls. And as expected, based on the mechanism of action, eculizumab binding, it did not affect formation of DSA, as evidenced by the similar incidence of DSA levels. Among the patients who developed high DSA, she stated in her abstract and her paper that the CD4 staining AMR was present in 15% of patients in eculizumab group. The 15% of patients in the eculizumab group and 100% in the control group. So it appears, at least in this setting, that as with many other diseases that involve complement, sepsis, HELP syndrome, eclampsia, et cetera, that inhibition of that complement can affect improved clinical outcome. So as I wind down, this is an abstract from last year's ASH, or American Society of Hematology meeting, and it describes a successful attempt to kind of try to find a biomarker to follow. So this group was able to show that in the setting, comparing two patients with plasma exchange and eculizumab, that in the setting of eculizumab, biomarkers of complement activation, endothelial activation, inflammation, coagulation, and renal injury used as a group were able to show that a complement was inhibited and the actual destruction associated with complement hyperactivity was improved. And primarily, from my discussions with them, that it was primarily the renal injury, and the way that they identified renal injuries are really through the urine. Again, because the serum really kind of dilutes the activity, because this is all cell surface stuff, but the urine, as it is excreted, will really have those markers present at the expected higher levels if they are still being injured. So that, I think, is actually the future, because we all know this is a very expensive drug. We all know that it's very difficult in the setting of an inpatient, sick patient, where this drug could affect an acute change, but again, with the cost, trying to weigh what we can do, which is probably one of the reasons why plasma exchange, plasma infusion is still used primarily in the acute setting, because it is so readily available. So we're hoping that these studies on biomarkers continue, and actually we've contacted them as well to try to see if we can kind of merge their biomarker studies with our genetic cohort to see if we can identify and correlate complement-related activity with clinical manifestations, or whether if they do have mutation, they have this little underlying injury constantly, and whether or not there's something that we can find as a threshold to really say that we need to intervene in this at this time. So that's Atypical HUS. Thanks for listening to me, and Merry Christmas, Happy Holidays.
And then the next line was 80%. I guess I'm asking, was it 80% of those who developed recurrent disease would then lose their graft?
Let's see, so that was way back, right?
Yeah, not halfway.
This one?
No.
No. Further?
Yeah.
This one?
Slide. So
Of those that recur, they can go on 80% of them.
Based on no additional intervention, or patients got plasma exchange, like, as far as recurrence leading to graft failure?
That was based off classical interventions, plasma exchange, chronic.
And then, I guess I have another quick question. 'Cause
Hmm.
So I trained in this center that uses Eculizumab for AMR, and so the whole point is that you're blocking the membrane attack complex from hurting the cells while the antibodies are present and turning on your complement system.
Yep.
And in this patient population, they have all these different defects that prevent their complement system from turning off appropriately or regulating itself appropriately. But what's turning it on? Is that we don't know?
What's turning on the complement? It's that classical pathway, that antibody-mediated classical pathway. All those donor-specific antibodies that are...
So post-transplant, you're developing antibodies to your new kidney graft.
Right.
People who just have native disease, we don't know, or do we?
Oh, you mean like a native atypical HUS? So native atypical HUS, I think of it more as a risk category. So think as like a factor V Leiden mutation in a coagulopathy. So they have that risk. So there are all sorts of other triggers, a virus, yeah, a little infection, anything that can really kind of set you over the edge. It may there may be cofactors involved genetically that we have Luke's family that adults are doing very well even though they have the mutation. And what set Luke off? Did he have a really nasty infection when he was younger that really just kind of started that whole process?
Because it seems reasonable that over time people should be able to come off the medication once that stimulus is down.
Absolutely.
And
And
the stimulus is.
and I think that's true. I think of it again like our hemophiliacs. If you can reduce the risk, don't go skydiving. You don't necessarily have to be on factor lifelong, but the global recommendation is being on factor lifelong will prevent you from developing musculoskeletal complications. But periodic factor and reducing that risk is just as ideal, and you don't necessarily have to be on factor. So it's that question of, do we have a biomarker that can tell us this person's really gonna manifest, this person's not, yeah. And we just don't have that, and I'm hoping a lot of these biomarker studies can really kind of help us in that instance, because it's really unnerving, and especially in patients post kidney transplant, they kind of constantly have some type of trigger, so to speak, to incite a complement, because it's a transplant. Yes, ma'am.